Welcome, everybody, to the Sapien podcast. I am here with my team from Valley View Hospice. So I've had a lot of requests to talk about hospice and end-of-life care. And I really wanted to be thoughtful about it. I wanted to make sure we had an interesting discussion. And so I'm going to introduce one of the best teams I work with. First of all, we have Andrew Stefanski, who is the owner. He's a serial entrepreneur, so he owns a lot of businesses, but really has a focus on geriatric care, right? So he's always, throughout the years, had businesses that supported older people. So he knows a lot about how to take care of older people, and he does a lot more than most owners to support us. And with him today, we have Tammi Harris, Dr. Tammi Harris. Tammi is amazing, you guys. Very few hospices are lucky enough to have a board certified nurse. She's board certified in geriatric care from Western University. Probably butchered that. She's also a specialist in quilting and has an amazing YouTube channel that you can find her out there. But me and Tammi work hand in hand. So she's the director of nursing for Valley View Hospice. I'm the medical director. We work together to provide the highest level of care. With Andrew, I also provide home health services for patients. In the past, he's provided everything from like transport to durable medical goods and just sort of this extensive home. It's really an extensive line of services for the home. So I wanted to introduce to my listeners all of these services and specifically end-of-life care because most people don't know about it, right? Most people are always, they're focused on the hospital care or their primary care physician, but they don't realize that we have a huge aging population and people need to stay out of the hospitals. And a lot of them can't go to their doctor anymore. So how do we take care of them at home? How do we take care of them when they go to a facility, a nursing home, a boarding care, an assisted living? So I'll start with Andrew. I just mentioned a bunch of these levels of care, right? And I think my listeners are like, what is he talking about? So Andrew, tell us a little bit about, these levels of care and how you service them.
So basically, we try to do everything we can to take care of the patient at home, like you said. So be it post-hip surgery, patient going home, needs some physical therapy, needs a nurse to stop by, make sure the medications are working out right with, of course, a consult from the physician, or end-of-life care where a patient has a terminal illness and they prefer to stay at home. Because in most cases, people don't even know that they have an option to basically set this whole hospital bed and all other equipment that you need at home to live out the rest of your life at home in comfort, surrounded by your loved ones. I think it's a big responsibility that we as a team have to allow that to be on us, on our shoulders, to be available for the family, to be available for the patient, and pretty much everything surrounding that. So from dealing with the patient's insurance to having a volunteer come in, set up their fridge, to answer a phone call from a son, a daughter that's not sure what stage of the transitioning into that part of life or death patient's on. So that's when I usually call you guys to have that clinical conversation with the patient's family, which is very important because essentially the person that's passing, they've most of the time come to terms if they're in hospice. But the family usually are the ones that have the, can we try this? Can we put some IV on this patient? Is there anything else we can do? And this is where they need the clinical insight of what's going to happen if you, for example, put an IV on a dying patient. What's going to happen if you start, radiation again? So yeah, I'm blessed to have a team such as you guys, and shout out, Dr. Gary is the first physician that I'm officially actually going to, being in this business since I was 15. It's very difficult to actually put your trust in a doctor these days that is just looking out for your health, not what they're able to bill for.
So like, it's so interesting because people think that, there's just a doctor, there's just a nurse. There's so much that goes into taking care of people. And I think what Andrew described is this, it's a really complicated insurance system. It's a really complicated process to get the equipment, the medications, the nursing staff, all of this. So, thank you for what you said, but like, we're blessed to have an owner, an operator who is willing to go above and beyond to make sure that patients get what they need. Because we can be as good as we can be, we can be supportive, all the things we're about to talk about. But like, if you don't have the support on the ownership side, if you don't have the support on the, look, we'll make a little less money, but we're going to do what is right for the patient. And that is always has to be the guiding light. Like, patient care is number one. Yes, it's a business. You're an entrepreneur. If you're not making money,
right,
what is the point, right? But you didn't talk about that. You talk, when we have conversations, when we, Dr. Tammi and Andrew, sit down, we're talking about what does the patient's family need? What does the patient need to get to, the next step in their process?
Right.
And that is never a financial conversation.
Correct.
That is always a conversation of logistics.
Right.
You're a producer, you're producing the situation.
Correct.
Right. So we thank you for that. We'll get back to some of the levels of care because I do want you to explain that, and I'll intro it again. But Dr. Tammi.
Yes.
So Dr. Tammi decided to become a geriatrician, essentially, right? You got your doctorate in it, and now most of your practice, if not all of it, right, is in hospice, end of life care. Why? Like, I know why I do it. Why did you choose to go down that path? And what drives you? Because you do your care with so much passion and so much heart. And as everyone who listens to this podcast knows, this one is really about spirituality. And that's what I connect with Dr. Tammi about, is she does it thinking about the spirit, thinking about the whole, right? Like we talk about holistic care. You really do. You deliver holistic care, from the medicine to the nursing to the medications to the, that touch, that moment where you're just there for it. So why and what drives you, Dr. Tammi?
So why do I do this? Speaking on the spiritual piece, I believe that this is a gift from God. It was bestowed upon me to do this work. I couldn't have made this up. It's very hard work. It's very challenging, but it is so incredibly rewarding. So I've been a nurse practitioner, geriatric nurse practitioner from UCLA since 2003. I've been a registered nurse since 1997. So what is that, like 20 plus years? It's been a while.
Yeah.
So geriatrics has always been my focus, because when I was in nursing school, we have to go through all the different specialties, and I did labor and delivery and pediatrics, and cried to my instructor through the first clinic. I'm like, please don't make me go back there. And so I was allowed to go to the emergency room, and then that's where I sort of knew that I wanted to take care of adults. But it was probably my first year of being a registered nurse that I realized I love old people. They do the darndest things. They say the darndest things. They're the best. And so ever since then, I've been taking care of old people, geriatrics. And so I believe that because this is a special gift that I have, that when I'm taking care of someone who is transitioning, it's not just that person, it's the whole family unit. And so when someone is transitioning and they're in that hallway, it's very important to recognize their physical issues as far as needing medications for symptom management. But in my opinion, it is first and foremost important to be able to assess and identify and treat their spiritual distress. There are a ton of medications I can use to manage shortness of breath, pain. But if you are in a spiritual distress, that really takes a special soul to help you transition through that. And so it's really hard for me to give you a didactic definition of what spiritual distress is, because it's unique. to everyone. But my overarching philosophy is, in this body that we have one chance to be born and one chance to die. Yeah. And it's very important for me that the patients and families that are under our care, that I do my best to make sure that is the most memorable experience in a positive way. We've all heard the horror stories of hospices where someone's symptoms weren't managed, some nurse was mean, they didn't get the diapers that they needed. Yeah. And you know what happens? What's that saying? That bad news travels further than good news? Yeah. And it's an indelible experience. I mean, we have a case literally right now. I saw one of our patients before I came for this podcast. She's 102 years old. Wow. She was square dancing up until the age of like 95. Oh. And she started her transition process about 16 hours ago. Her grandson is an ICU registered nurse. He's at the bedside and daughter's at bedside. And so it's difficult when you are taking care of someone who has a healthcare professional as a loved one, because you're like, they're watching me. Yeah. But that's where that gift came in, where I had to take over and say, this is where I take over and help. And so being able to recognize that that particular lady needed some help as far as breathing is concerned, and that I needed to pick up the phone and facilitate a conversation with a loved one who she hadn't spoke to, and tell that loved one, like, now is the time to say the words. That's a special gift and a special art, but in my opinion, that's the work that we do in hospice. You have to look at not only the patient, but the family members, because when this lady completes her transition, when she dies, guess who's left over? Yeah. This grandson, the daughter, that family member, and that's the memory that they'll have. And I do my best to make sure that that memory is a positive one.
That's beautiful.
Thank you.
And it's really something people should realize, that, hospice is not, it's not about expediting death, right? It's not about, I'm trying to demystify it. It's about creating a transition that's beautiful, and it's about the providers being there, and about providing not just for the family, but even for facilities. Mm-hmm. So kind of switching back a little bit, like, one of the things I love to work with Andrew is we support everywhere we work. So maybe I'll describe it, and then I'll ask you like how you do it, why you do it, because it's important. So when a patient is nearing the end of their life, not necessarily end of life, oftentimes families can't keep them at home. So families have choices, and I'm going to speak specifically to Los Angeles, California, but like there's versions of this in every state. And really, many countries have built models like this. Right. There is a level of care that we call here a boarding care. And that is a home, usually 4 or 6 bedrooms, where, elderly people and chronically ill people go to live, and they have caregivers. Then there's an assisted living, and that is an apartment building, just like you would think of, but with extra services like a kitchen, and with caretakers that will provide medications and, help with cleaning and sometimes even with bathing, things like that. Then there's what people consider a nursing home, or nowadays we call them rehabs. Mm-hmm. And these are facilities, because nursing home got a bad rep, so they switched to calling them rehabs. But these are places where people go that need more of a medical service. So there's RNs, so higher, like nurses like Tammi, and doctors like myself, rounding every day, and sort of not just caregivers, but a higher level of service. And so that's considered a nursing home. And sometimes people go there to rehabilitate, and sometimes people go there to live. And that's the reality of it. Right. There's other sort of in-betweens that exist, like if people are on ventilators, there's sort of these long-term facilities where they can manage the ventilator, but it's still a little more like an assisted living. It's still more of like an apartment, but there's someone there to manage the vent. There's group homes in other states, which are something also in between. They're usually more like the boarding care. We provide care in the hospice setting and in the home health setting in all of these places. Correct. So can you tell everyone a little bit about the difference between hospice and home health? Because I think that's a common confusion. Most people don't even know what home health is.
So home health, it's something that I've been passionate about and been trying to get into for many, many years, and just physically have not had the chance to do so up until kind of recently. But we've always kind of even provided that part of it for our palliative care hospice patients, because it kind of goes hand in hand in patient care. So anybody going home after a hospital stay, a surgery, a visit at the nursing home or a rehab center after surgery, they needed more active rehab. They go home.
Or an elderly patient who cannot go to a rehab or cannot go to a physical therapist or cannot go to the occupational therapist and needs those services at home or just boarding care.
So we'll come in, we'll set everything up in the patient's home. With home health, it's a little tricky because unlike hospice, the equipment is not covered. So we kind of like to go above and beyond. Everything that I'm involved in, and what Dr. Gary was saying is I can't have a financial conversation before the care. So the care has to come first. The financial conversation, unfortunately, has to happen in the background because bills need to be paid for. But so we provide our own DME. It's free to the patient.
DME is durable medical equipment.
Correct.
So this is like urinals, hospital beds, diapers,
bedside table, oxygen machine, a bar to hold yourself up as the physical therapist is coming in and needs to do certain exercises with you, an exercise bike. I mean, you name it, we provide it. We had to basically rent a storage, fill it up, and just have it available for our patients, free of charge. So that's basically what we're providing at the patient's home. If, like Dr. Gary said, they cannot go to a rehab, they cannot leave their home for whatever reason. So the home health aspect of it is, again, most patients leaving the hospital will get a referral for home health just to prevent them from coming back into the hospital setting, because it benefits everyone. The patient, the hospital, and of course, the insurance company, because...
because it should be explained. When a patient goes to the hospital, it's the most expensive part of care. So once a patient is discharged, every effort is made to prevent that patient from going back to the hospital.
Right.
So it is a financial consideration for everyone, but also going back and forth from the hospital is miserable for people.
Correct.
So home health provides these rehab services. I'll just extrapolate on what you said. They provide physical therapy, occupational therapy, speech therapy, and skilled nursing. And skilled nursing can go everything from monitoring blood pressure to monitoring blood sugars, sometimes providing IV and intramuscular medications.
Correct.
It's a very robust
wound
service.
care.
Wound care, thank you.
Wound care is huge. Yeah.
Wound care is so common where people are bedbound and they have ulcers and they can't go to a wound care center. Amputations. Yeah. No, it's great. I mean, it is a very robust service, and sometimes people abuse it. And what we want to emphasize is the importance of it to prevent hospitalization, to prevent things getting worse. However, people get worse. So sometimes we do our best in the home setting, and people don't get better. And that's where hospice and palliative care come in.
Right.
So Dr. Tammi, I think you'd be best to explain it, the difference between hospice and palliative care, because up until a few years ago, I was confused about it. There's a reality of clinical difference, right? Which I don't know, is that so different? I'm curious how you would describe it. And then there's the business side of things, because there is from a business side of things difference. So what is your interpretation of that difference? Because the legal definition versus what it really is in practice it can be ambiguous.
Okay, so the legal definition of palliative care is those patients who had a chronic or potentially terminal illness who still want to pursue aggressive measures. So this would be someone who has cancer and they're on chemo, but they have pain associated with that treatment. They have nausea or vomiting associated with that treatment. So the word palliative palliation is typically defined as to abate symptoms. And so palliative care will come in and take care of the nausea, take care of the vomiting, and take care of the pain, all while that person continues to pursue treatment. Hospice does the same symptom management, but when you are hospice criteria, when you're assigned to hospice, you have elected to no longer pursue aggressive treatment. So the thin line in the sand is the care is the same between palliative care and hospice. Both services will manage symptoms. The line in the sand is, are you wanting to continue to pursue aggressive treatment, or are you saying no to aggressive treatment? In my opinion, the palliative care is a stepping stone for hospice. A lot of times, family members and patients are not at a point where they can accept a terminal diagnosis. So even though the disease, if it progresses on its current trajectory for the next 6 to 12 months, we anticipate that person transitioning to death. That could be the same criteria for palliative care. It's just that the family and or the patient aren't ready to basically say, I accept that. So we offer them palliative care to allow them to continue those aggressive treatments, even though the prognosis is the same 6 months to 12 months if the disease continues.
Yeah.
And so that's why Dr. Gary was mentioning it's a thin line, because the care is the same. It's just where that patient and their family are in accepting that terminal diagnosis.
So on the business side,
I'll bring it up. Palliative care is more accepted by the HMOs because it's a huge money saver for them, because they're able to hire somebody like us, have us, like Dr. Tammi said, manage all the symptoms, deal with everything that usually the patient has to deal with in the family, but for a fraction of the price. We've had cases where the healthcare provider, the HMO will push on the healthcare provider to keep the patient on palliative care just because the patient's family doesn't want to hear hospice, which is ridiculous. And it kind of ties our hands in how aggressive we can be with the comfort care and treatment. And at the end, the patients are not receiving the care that they could have just because of that little technicality. And like Dr. Gary said, when you elect hospice, as I think, in my opinion, is when you can actually, in today's environment, more or less take control of your own healthcare, where you're saying, okay, I've had enough. I know this is happening. Let me just enjoy the last month, 6 months, a day of my life where I know I'm at home with my loved one. I'm at a boarding care. I'm at a nursing home, wherever they want to be. We'll set up whatever they need. Again, so that on the business end, that's kind of where I see the difference between palliative and hospice. But again, on our end, on the clinical end, it's kind of the same.
Yeah.
And I like to say that I feel the work we do, we are helping people to live while they're dying. Does that make sense?
really good.
So we're helping them live their best life in the light of they have a diagnosis that is terminating their life. A lot of people think hospice is, oh, that's where you go and they give you morphine and you die. And that is not the case.
No.
It is the case for some people, and that's because the referral was delayed to a point where that person is suffering. And when you take care of their symptoms, they're comfortable and they transition. But the goal of hospice is to get people on sooner versus later.
And it's quite rare, actually.
It is rare that happens, but it's better to get them on so they can establish the relationship with the team and that we can help them live their best life.
I think most people are in denial about the slides to begin with. So when it comes to death, I think it just brings up more denial about it.
And the other thing is we work in this system that is designed to do what? Save you, save you, save you, save you, save you.
Right.
And so we have a case where the caregiver said, well, she's got an infection, so give her antibiotics.
Right.
Well, we can't give antibiotics for someone who's going through a natural process called dying.
Right.
But we've trained family members to think that, oh, well, just give antibiotics or take them to the hospital. It's a quick fix. And it's like, no, this person's transitioning. It's not the solution. So I would like to be a voice to start helping the community understand that it is okay to be comfortable and it is okay to not pursue aggressive measures, because despite what the healthcare system is telling you, or dial 911, go to the hospital, unfortunately, we all have a day and time that we're going to transition. And sometimes the interventions just make you suffer versus solving the problem.
It's about quality of life.
Correct.
And if
We don't have it, what's the point of keeping your loved ones miserable and yourself? And I get it that it's very difficult for a loved one to let go of their parent, their grandparent. Maybe there's some unsaid stuff that we end up having to deal with on the back end or on the front end. Often we get kids that lost contact with their parents that come into the picture, and they just want to do everything, and they expect us to, create a miracle. Unfortunately, that's not how it works. All of that I'm willing to listen to and give you some direction to a degree, but that's something that you have that opportunity to work that out with your parent, get that out of your system. It takes all kinds. We have stressful cases, and we have cases where, I've witnessed personally a situation where the kids of a loved one that just passed, I happened to meet them outside of the house, and both of them had tears of joy, and both of them basically just hugged me and said, "Thank you for everything that you guys have done." I think you know the case, and whatever stress, whatever was going on with all the BS just went away for that few minutes. And it was a beautiful, beautiful thing to see for me. Another case is a good friend of Dr. Tammy's and I wanted to say this in the beginning, but at dinner randomly with a group of people, and as I'm leaving, this young lady comes up and she says, "Oh, wow, you guys are doing this tomorrow." So mention the fact that Dr. Tammi has seen a few of my loved ones. Three. Pass on to the next life. And all three were beautiful experiences. And that's a huge deal. I mean, often we have families that, we ended up helping with their father, then we would help with the mother or another family member. So it really feels great for us to know that we were able to help, whether it be calling the insurance company, answering questions that they just couldn't get an answer for anywhere, and being there for them till the very last breath. It means a lot.
I don't know if it comes across on the podcast, but all of us got emotional just talking about that. And it's like, where in the healthcare system do you have that kind of experience? Because I've been in all levels, and it's very, anyone who does geriatric medicine and end of life care, it is heavy. Yeah. It is by nature heavy. And we're here to talk about it because people need to hear it, because it's coming for everyone listening.
Correct.
Everyone will encounter us or some form of us, right? And there is a right way to do it, and it is with spirituality and heart. And I hope it translates. Like, I wanted to have like the business side and the clinical side. And it's like, if you're doing it right, we're doing the same thing.
Right.
These encounters are the same because it's so difficult. It is so mystified, right?
Yeah.
It is so in this realm of, I don't know, it's not part of our lives. Death is not part of our lives.
Correct.
It used to be. I always say this, like 100 years ago, there's this great study by the Institute of Health when palliative care and hospice was promoted, I think early 90s. They did a great study, and they showed that like in the early 1900s, 20% of deaths happened in the hospital and like 80% happened at home. Hospital or like,
Right.
nursing home setting, right? And so people knew what death was. They knew what it was like. They knew the feelings about it. They knew the heaviness. They knew that it was a reality. As of that study, they were looking in the 80s and 90s, and it had flipped completely, right? 80% of people were dying in the hospital and 20% were dying at home. And what that told me is that that's the disconnect. There's this little bit of magical thinking that the hospital is going to like save your life and it's going to like change what's really going on. And the reality is the healthcare system, as you guys mentioned, is a promotion of disease. They make money on and propagate disease. And we are in the business of helping people transition out of that system and into this, you put it better, Andrew, this like reality of like, this is, or one of you guys said it, like, this is where it's going. And we're here to help everyone, including the patient. And often it's not the patient knows what's happening, right? It's the families that we're steering through and being like, hey guys, we are here and it's time to focus on quality and it's time to give them the moments that they can together. And it's time to stop freaking out and feeling guilty and feeling anxious and just be present and be there for the moments that are left. So it's just interesting because we all do this all the time. You've been doing it for 20 years and Andrew's been in it for 15 years. I've been doing this for a decade. It's still very emotional. It's still because it is.
It's real. It's real. And we've sterilized, as you're saying, Dr. Gary, Western society in the United States, death has been sterilized. We don't see it. It's hidden from us. It happens in the hospital. It doesn't happen at home. They don't even like identify Hirsch's anymore. Like when they come to final responders, they're called. Did you know that? Final responders are the mortuary industry. They like to be referred to as the final responders. And often when they show up, they're in the vehicle that's sort of inconspicuous. I mean, you would know. It's not something that you would go, someone has passed away and they're in that vehicle. You don't even know.
Oh, I see. It doesn't look like her.
No, it doesn't. Like, remember, it used to be like the hearse or something, like a mortuary.
Oh, they used to be like walks down the street and people used to be
seeing those white vans. It's like, it's so sterilized. And so I think that's part of the issue is that we don't see it. And so because we don't see it, we turn a blind eye to it and we pretend it's not happening. But it will happen to all of us. It will happen to all.
I mean, I think it speaks about where our culture and Western society is going: denial. And this is just, I think, one of the ways of masking of the inevitable. We're all going to die. Just a matter of how we live, right? So, talking about beautiful experiences, we often get calls from friends, families. Hey, my grandma, my father, my mother are going through this. Can you help out? So of course we, come out, we do what we do. And one experience that just recently happened, it's a friend of mine. He's in healthcare on the business end. His father, what a fighter. He got diagnosed with cancer, fought it for a year, had one of the legs amputated while he was on chemo, which was like a huge deal, and ended up just one day saying, "Hey guys, stop, enough. I'm good. And because they were all in healthcare, the family, they kind of embraced it and took with it. And the experience was, I'm in the house. saying my goodbyes, and in a nice way. And the gentleman mentioned that he's having a hard time sleeping. So I said, okay, no worries. So I left, came back, brought some edibles. So we all took a gummy bear and bonded.
Love that.
Had a great time.
For the team.
Had a great time. The wife, because this guy was on the young side in his early 60s. The wife is still having a very hard time sleeping. And she's still taking some of those gummies once in a while and calling and texting saying, Andrew, thank you. So again, it's, it could be a beautiful thing. It doesn't have to be a negative experience every time. And as long as we embrace it and we understand it, it could be a wonderful thing. It could be something that our society finally needs to embrace and face and maybe learn more about how to deal with it.
Absolutely, because we have the baby boomers going into their late 70s. We have to.
Yeah.
Hospice currently is a $30 billion business, and in the next 7 to 10 years will become a $60 billion business.
Yeah.
I mean, and that's not to say that it's so lucrative. That's to say that that is where the population is heading.
Right.
There's no avoiding this, right? So I'm this funny doctor who talks about like nutrition and anti-aging, and we're going to do another episode here shortly where we're going to talk about peptides, which I think are phenomenal. But I'm on both ends of it because that is the world that we are really in. We're in an aging elderly population that will be going through the dying process, and a young population that is chronically ill, getting really bad advice, guided by a system only motivated to create chronic disease states. So yeah, that's my connection. Like, why do I talk about hospice? And then why do I talk about food? Because it's, to me, lifestyle medicine.
Yeah.
Everything we just talked about, all these stories you're sharing and everything we do, we're guiding spirituality. We're guiding families. The medicine part is easy. It's easy.
Right.
The business, the actual thing we do every day is guiding the lifestyle. And so when we're talking over here about people need to wake up or people need to listen and talk about hospice, it's because that is part of our lives. And that is a lifestyle practice of understanding when it's time and understanding to give room for comfort and room and space for someone to pass. How often is it where we give that guidance to like a family member of give permission to your family member. Stop holding on. They've been dying for years sometimes, and you have to give them permission on a spiritual level. It will help. Yes, it will help. We see it happen, and that's lifestyle medicine, right? I wanted to make that connection because that's what we just talked about. We're just talking about lifestyle practices.
Right.
Very interesting. And thank you for sharing. I also want to share one quick story. We're talking about all these beautiful situations. I actually was on a call last night with someone, and it's like they're propagating. This lady has advanced dementia. She's young, like 67.
Wow.
No cognitive faculties are left. She had traumatic brain injury and a number of insults, and likely it's a combination of different factors causing her brain disease, and she's gone. And the kids are struggling because they're like, we can't watch her suffer. It's been 10 years. What can you do, doctor? And I wanted to bring this up because it's a tough subject.
Yeah.
Physician aid in dying. And it's really, really heavy. And I'll let you speak on it, definitely, Tammi. But it is, one, hard to talk about. Two, the legality and the laws are often very weird to understand and different state to state and country to country. You guys, listening around the world, like it's different everywhere. It's morally and ethically a very challenging situation. But anyway, like my example was this lady and she's suffering, and they're like, I'm limited in California what I can do. In order to go through physician aid in dying, you have to be cognitively intact. You have to shoot a video and you have to Yeah, you know that in California?
No.
Oh, the process to do physician aid in dying requires, there's only a handful of physicians that are qualified to basically go through that process. And then me as the hospice or primary doctor can support them, but they have to hire the special doctor with the special certification. Then they have to go through this evaluation. They have to videotape their, it's like an affidavit. Then it takes months. It's extremely expensive. I think it's in the order of tens of thousands of dollars to go through this whole process to get it done. And then they have to have the mental and physical faculties to take the medicine and dispense it to themselves. So, if you have a demented patient like I had, and they're just suffering, right? And the 3 kids are sitting there like, I can't, we've hit our limit. This is awful. I can't help them. I can't expedite death. I can't do that. It's illegal and it's morally difficult, right? So I had this very convoluted discussion, which is very different than the discussions you guys described, where I'm not guiding them to accept it. I'm explaining to them how I can't just give her a lethal dose and it is miserable and hard to watch, but that I can do comfort care, and we have our parameters and our rules, and it's different in other countries and other states. And I just wanted to counterpoint these stories of, we do thousands of cases and they're all different.
Correct.
And they're all heavy.
Yeah.
That conversation at 7 p.m. while my wife was waiting to have dinner was heavy.
Yeah.
Getting on FaceTime.
Yeah.
Why did I do that? Because the family just needed me to know that I knew, and I was like, I know. And these are your options, right? It's real medicine, and it's real heavy stuff, and it's lifestyle medicine. What are your thoughts, Dr. Tammi? I know you have a lot. We've had these conversations.
Oh, my stars. Oh, my stars. So in that situation, I think was she able to feed herself?
No, she is so cognitively declined. She is being fed by the caregivers. So one of the questions is, can we just stop feeding her?
Right.
Which is, I'm like, you can. I don't want to. That's a very heavy discussion for another time, and I'm going to leave that to. If you're interested, you could DM me and we can talk about it. And if this is something that is attractive, the heavy layered things that happen when people are transitioning, we can get into that. I just don't know that that's for this podcast today. So I'm not going to say what I said. It's hard. Yeah. It is hard. Can I say one more story? One quick story. I had this 45-year-old bodybuilder come in. He had been bodybuilding and taking all the testosterone and all the growth hormone. And he's like, I'm going to be your patient. And I'm like, oh my God, I'm worried you have cancer. And he's like, well, I have the CT scan from 2 years ago and there were spots on my brain and on my chest. And I was like, oh. And he's like, yeah, I don't know. I just never followed it up. I was just doing my thing. And I'm like, can I scan you again? So I scanned him again and he had cancer everywhere. And he's like 47 at this time. And he's sitting there with his 18-year-old daughter. And I'm telling him he has cancer. And so, he had made the choice not to follow up the scans. He had made all these choices. And I'm like, well, what do you want to do? So he goes to the oncologist. He gets all these options for treatment. They're like, there is nothing. They gave him some chemo, some radiation. It was progressing further. So he went through the physician aid in dying experience. I connected him with the doctor. I co-signed. That's how I learned about it. That was my first case with it. Co-signed it. He did the video thing. He had everything, the whole way, which took about 3 months. And at that point, he had lost, 100 pounds and was a shell of himself. And even his daughter was on board because she's like, this is its time. He's got the medicine that far, but the medicine was there. And then it was just his choice to take it or not. His brother shows up from another country and he's like, no, you can't do it. And the surgeons had offered him a brain surgery to cut out one of the masses. And he asked me what to do. I'm like, well, is it a curative surgery? He's like, no. I'm like, it's just a palliative. I'm like, but what's it going to do? He's like, well, I don't know. I'm like, neither do I. And when I read the note from the surgeons, I was like, why did you even offer this? Because it's not going to change anything. Well, so I recommended he continue hospice care and do what he needs to do to complete or not complete. He didn't have to take the medicine. So I didn't guide him on that. I was just like, you're going through the process, right? Well, the brother convinces him through a very which he told me later, a very guilt-ridden experience, to do the surgery. And what happened? The surgery left him functional quadriplegic, which means he could no longer use his arms, which means he could no longer administer the medication to himself, which means he could not go through complete the process. He proceeded to wither away for the next 3 months, asking to be given that medication. I or my hospice team could not participate in that. His daughter was unwilling to give him the medicine for a number of obvious reasons. And he passed, uncomfortable and miserable, basically. And it was heartbreaking and just a tough story that people should understand. It's very, very, very difficult, these processes. And speaking to Andrew's points about families getting involved, and then the subtleties of the rules that exist. And I was devastated. I was literally, that took me like a while to recover from, because he kept asking me to give him the meds. And I'm like, I can do comfort care and symptom management and control, but he was done and he couldn't do it.
And that's the thing, the audience should understand, is that sometimes when surgeries and treatments are offered, Dr. Gary, you had a very good point about asking, what will this do? What will this change? And if the answer isn't curative, we'll just remove the tumor or, it's that situation where it's like, I thought you were going to say stroke, but I had, it's kind of like the poor guy, and family members, they mean the best, but in my experience, 80% of the time, the family members only thinking about themselves. That brother was thinking about himself.
Guilt, because he wasn't there the whole time, and he showed up at the last moment and felt so guilty, and he pushed them on it. And it's hard. It's hard. How do you tell a brother, like, sorry, you missed the boat. Be there for him, but don't.
Yeah.
That was tough.
It's tough, yeah.
What are your thoughts on physician aid? We're going to run out of time, but I know you have super strong feelings about it. I don't know. Just generally, what are your thoughts? What are your experiences? Is it something that you think is important? Is it something you think is we're doing a good job with, or not a good job with here, at least here in California where we practice?
I think that from a medical standpoint, that people should have the right to choose. So if they can go through the criteria that you described and that's their choice, absolutely, they should be able to do that. I myself don't have any firsthand experience of it, but I think that spiritually, I've seen people die spiritually and their body is still functioning, but because they have decided that they were done and the body is still going, it's like, which one is worse? And so as far as like, it's to each his own, but I think that, yes, people should have the choice. I think that spiritually, it's very personal to that patient, and that I would like to see, and I don't know if it exists, but I would like to see more of family unit, like a consultation or some sort of assessment, because from being a nurse, I want to look at the family unit, because if I know that brother was lurking, I want to talk to him before he shows up and says, don't do it. So I think that that would be the element that I would add to this process, is sort of the evaluation of the family unit. And are there any sort of skeletons in the closet that need to be addressed? But other than that, I think that to each his own. I think it's good. I think that people should have choices. Yeah. And we live in a state that offers that choice, and it should be protected. Yeah. What would I like to say? None of us are in a position to judge. And it's up to that person and their spirituality and their belief system to make that decision. What I will say is that, and this kind of crosses the line with hospice, as a healthcare professional, you need to know where you stand on these issues. I come across it frequently in hospice. I know of nurses who are not comfortable with delivering certain levels of hospice care. Right. I know one nurse in particular who will do the routine visits, but when it comes to continuous care, which is continuous care is a level of service where, as a team, if Dr. Gary decides that this person is within the last 3 to 5 days of life and they require symptom management, like they need medicines every hour, every 2 hours, we're allowed to put a licensed nurse at the bedside and administer those medications so that the patient dies comfortably. I know of a nurse who that's her line in the sand. I finally have getting her to a point where she can acknowledge that, and that's okay. So with the physician-assisted suicide, with palliative care, with hospice, the healthcare provider needs to know thyself and respect thyself.
Good.
So if that is not your lane, don't put your blinker on and get in it. Stay in your lane. And if we can do that as professionals, that's more service to the patient. Because if you, as yourself, are uncomfortable with administering morphine, that's typically one that gets people riled up. If you're not comfortable with that, then you should not participate. So with the physician-assisted suicide, again, we just have to own it. And I'm not perfect, but I've been very good about leaving my values and not my values, but leaving a lot at the door. When I'm with the patient, I am there for that patient and their family. I've been in situations where there are things that I don't agree with, but it isn't about me, it's about them. Yeah. And so as long as my safety isn't in jeopardy, I'm present with that family. But there have been times where I go, this is my line in the sand, and I will remove myself because I will not cross that line. And so it's just a matter of, knowing thyself and knowing that you're there first for that family and the patient and upholding that.
Yeah, again, gets back to honesty with yourself, like you said. Yeah, and I'm actually surprised that it's that difficult in the state to go through doctor assisted.
Well, the fact that we even have it, it's very rare in America. So,
I mean, considering we have other surgeries that are just done left and right in the state.
All right, thank you, Andrew. On that note, I want to thank you guys. That was a really, really heavy discussion, and I think people are really going to appreciate it. And it's something that people need to hear, and you guys are really brave to talk about it because people don't want to talk about it. So I do want to give Andrew. You don't want to share your quilting YouTube channel? No. Okay, but you can find Dr. Tammi somewhere on YouTube quilting. You can find her working with me at Valley View Hospice. Andrew, do you want to share if anyone is interested in learning more about the services, home health, hospice, how they can reach out?
Yeah, we have a website for both the home health, which is Oak Tree Home Health, and the hospice agency, Valley View Hospice. You can Google us and it'll come up.
Good. Okay.
I will say on the quilting note, and that the reason why I quilt, I think this is important, and the reason why I quilt is as we've been having this discussion, talking about how heavy this work is, quilting is my therapy. And so that's the way I replenish myself. And I specialize in making memory quilts, and I specialize in making projects for people who have lost a loved one. So if you're interested, then you can reach out to Dr. Gary, and then I will get back to
fine.
Because I make projects on commission, like I can do that. So I don't want to share my channel because I'm therapist.
Okay.
But if you're interested in learning more about what I do as a quilter and helping people during the grieving process, just reach out to Dr. Gary.
Yeah, reach out to me. We do meetings all the time. We're always on the horn. So until next time, thank you, everybody.
Thank you.
Bye.